it says plans for the future. And I just thought, well, the plans for the future, let's just look at the 3 biggest challenges that are ahead of us. And the first of them is that we, and I bear no likeness to the other Alan Dow who was up only a few minutes ago, speaking now as a GP and chair of Tameside and Glossop CCG, clinical commissioning group. One of the challenges is that we are a clinical commissioner. Now, don't get me wrong, I think it is fantastic that we have a clinical commissioning group. So finally, and I've been involved in healthcare things for a while, finally we have a structure that lets clinicians make decisions about things that matter clinically. That makes sense, and it seems to be working. We have a much richer dialogue with our local hospital clinicians, and in fact, a much more incisive view on what is a dead end, what is likely to succeed, what is going to work, what isn't going to work, what are the problems, what are the blocks, how do we get round them. So there's lots of things that are good, but it's clinical. And people have problems that are broader than clinical. In fact, picking up something that Ian has just said, if you remember the slide of the pillars, I bet you we would get different answers even about what primary care is if we asked the panel. And you would think primary care, well, we know what primary care is. Is community nursing part of primary care? It's not always in the hospital, it's out of the hospital, therefore it must be primary care. But actually, is primary care not where you can go if you have an undifferentiated problem? There's somebody who is an autonomous practitioner that you can turn up to and say, I've got a problem. And they can either sort it, or they can say, nah, it's not me, you need to go somewhere else. And therefore, going back to Ian's slide with the pillars, which are general practice is undoubtedly in there, and pharmacy, but so is optometry, and so is dentistry. And actually, what about physio? Optometry, podiatry. If you went to see a podiatrist with a foot, they have a fantastic level of knowledge and skills about what feet do, and they would direct you to the right place. What about actually a debt advisor? A lot of people, and Richard said the same, come in with problems that are social. What if they go there first, and actually instead of coming in to see a GP, not because I'm not interested, but because I'm not an expert, and somebody else is. So, broadening it out from clinical, and the first step, it is including social care. So we want to be a commissioner of not just medical things, but social things as well. And that's a joint agreement with the council to go forward. And we're calling it the Joint Commission, so it's no longer about commissioning health and social care in 2 different places. It's about bringing that decision making together and actually say, when we look at it in the round, if the money is spent there and it isn't spent there, is that the best way to do it? And for that body to take shape, we want to begin making these decisions and set up that process from early in this new year. We've already in a shadow year of sharing a budget, and from the new year we will have systems in place where the team that has formerly been 2 different teams is now 1 single team making the decisions. So that's a big thing. That's a challenging timescale. It's quite huge, really. I don't know if we have time for the story or not. I don't know how time challenged we are.
Short one, isn't it?
A very short story, and there's a few good ones, and Richard's got a cracking one if it comes up as well. But it's a lady that I saw not that long ago who was looking after her husband with dementia. She has bad knees, she has cancer, she has problems with her cancer, unfortunately. But what stopped her being able to look after her husband was her knee, which looked exactly the same to me as it did any other day, was so bad she couldn't get off the chair. She had got up, she had made breakfast, she was in the chair, she couldn't get up the chair. She's looking after her husband with dementia, she can't get off the chair. It's just a disaster, isn't it? In the old days, she ends up being a hospital admission because there's nothing I can do with her knee. He goes into care or respite or emergency placement. The son, who's very, very willing, but he's got a job a long way away. I mean, it's just like dominoes falling down. What we did was we got a service that combines health and social care. They went round to see her. They got the son in to look after the dad, to put up a bed in the living room, brought it downstairs because they couldn't move. They got the ambulance to give the lady Entonox just so that they could get her to a place of safety so she could look after herself. They got the physio round, and true story, 2 days later with intensive physio, she was walking again. She had been at home the whole time and she was still looking after her husband. But the story to me shows how far down that does the medical model go. It just stops, doesn't it? It doesn't take you anywhere unless you combine it. We're looking at the same in terms of provision. So previously, we have what are called handoffs. It's not my job, it's your job. No, it's your job. No, it's my job. And they're not efficient and the patient is in the middle. And what we want to do is we want to bring the core of the provision together in what's called an integrated care organisation. And they're all the rage, and they do mean having community nursing, working with a hospital, so that it's no longer two competing organisations. It means general practices being aligned in pharmacies and other organisations being aligned. But even then, is it broad enough? We certainly must have social care in that organisation, or again we've got a half response. But what about mental health? Running through everything, underpinning everything, but actually, after 20 years of evolution, in totally different units of provision. Huge, massive mental health trusts. How do we get them in that same construct so an individual with a whole myriad of problems gets a solution that actually sorts them and fits them? And then the last challenge is the age that we're in with financial problems on all sides. The Trust, as hospital, has got challenges for its finances. The CCG is probably having one of our most difficult years since we've had, and of course social care and the size of the cuts that have happened and are ahead. How do we make things better in the context of being in an age of austerity when everybody wants to take money out of the system? And even when you hold pace, if funding were frozen and people get older with more problems, of course, what was enough yesterday isn't going to be enough tomorrow, let alone when you take money out of the system. And the temptation, as is always the way, is to cut the things that you don't feel today, to cut the investment in what might be health promotion or prevention that is down the lines. And it just strikes me that if we as clinical commissioners cannot say we can't do that, then I guess nobody's going to say we can't do that. Because the temptation to cut what is cuttable is huge. You have a statutory function to balance the books. You cannot go into the supermarket with no money and say I want to borrow, and actually it's much the same. We must pay the bill, but if we cut prevention, I know, it's not deep, it's not clever, I know with my clinical hat on, we are making things worse for 10 years in the future when these problems come through. Have we got the courage to say we cannot stop investing in prevention, in primary care and out of hospital care? And if we freeze our budgets, which is another reaction, another temptation, I think we're similarly destined to fail. The day we say we cannot commission, we cannot pay for a good idea that is better than yesterday's idea, I think that's the end of the road. So the temptation is there, but we must have the drive to keep going and not freeze and put the most important things first.